Most people assume swallowing is simple and automatic, something your body just does without you having to think about it. But swallowing is actually one of the most complex acts the human body performs, involving dozens of muscles and multiple nerves working in precise coordination every single time you eat or drink. When swallowing breaks down, the consequences can be serious. We're talking dehydration, malnutrition, chest infections, and, in some cases, even death. That breakdown has a name, and in this video I'm going to explain exactly what it is. Hi, I'm Richard. I'm a speech and language therapist and a lecturer based in the UK. In this video, I'll explain what dysphagia is, what causes it, and what signs and symptoms you should look out for. Dysphagia comes from the Greek word dys, meaning difficulty, and phagia, meaning eating or swallowing. So simply put, dysphagia means difficulty swallowing. Dysphagia is the term we use to describe a sign or symptom. It's not a diagnosis in itself. So just as pain tells you something's wrong with the body, but not exactly what, dysphagia tells you something's wrong with swallowing. Speech and language therapists break down swallowing into different stages, and we name these after the part of the body where they occur. Before food or drink even enters the mouth, we've got the pre-oral stage, where we anticipate and prepare for the meal, such as looking at your food and starting to secrete more saliva containing enzymes that help break it down. Then we've got the oral phase, named after the oral cavity or your mouth, where food is chewed up and formed into a consistency that can be swallowed, and we call this a bolus. Then we have the pharyngeal phase, named after the pharynx, where the bolus is propelled through the throat while the airway is protected. And finally, we have the oesophageal phase, named after the esophagus or your gullet, where the bolus travels down into your stomach. Dysphagia can occur at any one of these stages or across several of them all at once. Now, when we talk about dysphagia, clinicians typically divide it into two broad categories based upon where the swallowing breakdown happens. The first is oropharyngeal dysphagia. This is where the difficulty happens in the mouth, throat, or the top part of the esophagus. This is the type of dysphagia that speech and language therapists like myself assess and manage. The second is oesophageal dysphagia, where the problem is lower down in the esophagus itself. This is more typically managed by doctors called gastroenterologists and may involve structural problems or motility issues in the esophagus itself. The two types can sometimes overlap, and it's not always a clear distinction, but understanding which part of the system is affected is a key first step in assessment. So what causes dysphagia? There are many possible causes, and it's often helpful to group them together. The first and most common group is neurological causes. Swallowing is a neurologically driven process. It requires precise signaling from the brainstem, and multiple nerves which innervate the face, the mouth, and the throat. When any part of this system is damaged, swallowing can be affected. There are a couple of reasons why dysphagia happens. First, sensation. Before a swallow can even be triggered, the brain needs sensory information about the texture, temperature, and position of the food or liquid in the mouth. If sensation is impaired, the information doesn't reach the brain accurately, which can delay or disrupt the swallow response. It also means the person may have reduced awareness of food or liquid remaining in their mouth or throat after swallowing. Second, motor signaling. Once the brain has sensory information about the kind of bolus in the mouth, it sends precise signals down to the muscles involved, telling the lips to close to prevent anything escaping out the front of the mouth, telling the tongue to move the food around the mouth and the jaw to move up and down so teeth break down the food into a bolus. Once the bolus reaches the back of the mouth, signals trigger a swallow response which closes off the nasal cavity and airway so food goes down into the esophagus. If those signals don't get through, or don't get through consistently, the muscles don't activate correctly. They may be weaker, or there might not be sufficient force to propel the bolus through the throat safely. The timing may be off, and muscles may activate more slowly than they should, so the airway may not close when it should. Third, coordination. Even if the individual muscles are receiving signals, the swallow requires all of these structures to work together in a tightly sequenced pattern. Damage to the neural systems responsible for that coordination, particularly at the level of the brainstem at the back of your head, can mean that the sequence breaks down, even when the muscles themselves retain some function or strength. So muscles involved in preventing food or liquid entering the airway, for instance, they may work, but they do not activate in time when the bolus is swallowed, so the airway is left open when the bolus arrives. Conditions like a stroke, Parkinson's disease, motor neuron disease, multiple sclerosis, dementia, and acquired brain injuries such as those from a head injury or following a cardiac arrest can affect normal sensation, motor signalling, and coordination in different ways and to different degrees, depending on where and how severely the nervous system is damaged. The second group is structural or mechanical causes, where something in the physical anatomy of the mouth, throat, or esophagus is altered. The structure of the muscles themselves may be altered, as say if there's a tumour. This may affect the size and shape directly, or affect the normal movement of the bolus through the throat and esophagus. Sometimes there are other anatomical abnormalities, such as pouches in the throat, where the bolus gets trapped. Maybe there are strictures in the esophagus which narrow the channel where the bolus can pass through before it reaches the stomach. Or maybe there's fistulas, which are holes or openings in tissues, so the bolus leaks into areas it should not. Conditions like head and neck cancer can cause dysphagia themselves, but the way that we treat them can also cause mechanical issues. Radiotherapy can cause fibrosis, so tissues become scarred and stiff. It also damages cells in your salivary glands, so they produce less saliva than normal, making it more difficult to swallow. Chemotherapy can inflame and cause ulceration of the soft tissues which line the mouth and throat, making swallowing more painful as well. Surgery to the mouth, jaw, tongue or throat can significantly affect the normal anatomy of the swallowing musculature. But surgery to other parts of the body can also indirectly cause dysphagia due to accidental damage to nerves or inflammation of the swallowing tissues, which sometimes have to be temporarily moved during surgery to gain access to deeper structures. Examples include surgery to the cervical spine at the top of your neck, aortic aneurysm repairs, or lung resections. There may also sometimes be physical objects inserted into somebody's head and neck to help them breathe, such as an endotracheal tube which is inserted into the mouth, or a tracheostomy tube which is inserted into somebody's neck. These are sometimes inserted in an emergency situation and can cause damage to the larynx, i.e. the voice box, and the swallowing muscles as well. Or sometimes this is a planned thing and might involve surgically creating an opening in the neck itself. The third group is functional or psychogenic causes, where no identifiable neurological or structural cause has been found, but the patient still experiences dysphagia. Of course, there are lots of other causes which contribute towards dysphagia, but they are not so easily grouped or perhaps cut across several groups discussed already. Anytime someone has prolonged illness or has not been eating and drinking normally for a little while, the muscles become deconditioned. This means they become weakened from disuse. This is especially important in older adults who may also have sarcopenia, which is age-related muscle wasting, or they may be medically frail, so their natural reserves to combat illness were already low to begin with. Gastroesophageal reflux disease, where stomach acid repeatedly irritates the lining of the esophagus and throat, can also contribute towards swallowing difficulties. Sometimes medications people take can also contribute to dysphagia, reducing saliva production, irritating the mucosal lining, causing sedation or reduced muscle tone, or producing abnormal movements that can affect the coordination of the swallow. These are just some of the most common causes of dysphagia, but it is by no means exhaustive. Now we know what causes dysphagia, let's talk about what it actually looks like. Some signs are quite easy to spot, such as choking, but others are more subtle, so I will break these down by the different stages I mentioned at the beginning. In the preoral stage, maybe someone avoids foods with a certain texture, or in severe cases like severe anxiety or eating disorders, avoids eating and drinking altogether. Maybe somebody has cognitive difficulties, so they do not initiate getting something to eat or drink, or get distracted during meal times, which then takes significantly longer, so their food gets cold and they eat very little, or they need someone to keep an eye on them. Maybe they have difficulty manipulating cutlery and physically getting food to their mouth. In severe cases, they might need someone to feed them. They might not be able to manage their saliva and drool, or maybe they cannot open their mouth very far due to muscle problems, which we call trismus, or a jaw fracture. Now for the oral stage. Food or liquid could leak out of their mouth because the lip muscles have low muscle tone or are weak. Perhaps the person has difficulty chewing, so they cannot break food down adequately. Maybe they can chew, but it is slow and effortful, so they get tired quickly and don't eat very much. Maybe they find it difficult to form a cohesive bolus because the tongue is weak, has reduced range of movement, or they have reduced saliva, so food scatters around the mouth. As mentioned before in the neurological group of conditions, maybe someone has reduced oral sensation and they are unaware when bits of food are left over in the mouth, for example, pocketing in the cheeks. In some cases, the food or liquid might fall into the throat before swallow is triggered. In the pharyngeal stage, the bolus might come out of somebody's nose rather than being swallowed. We call that nasal regurgitation. If the food or drink goes down the right way, somebody still might end up coughing during or after a swallow. If there is some food or liquid near the vocal cords, their voice might sound wet or gurgly. Sometimes people experience the sensation of food sticking in their throat, so they clear or cough forcefully, often multiple times. Sometimes the swallowing muscles are genuinely weak or uncoordinated, and it takes multiple swallows to get something down, especially if they've not used them for a while. If some food or liquid manages to get past the vocal cords, which usually prevent things going down into the lungs, we call this aspiration. Sometimes people have no or limited sensation of things entering the airway, so they make no attempt to clear it. We call that silent aspiration. Sometimes you see the body respond to this with changes in colour to the face, such as becoming flushed or pallor. People often sweat, their eyes water, their face grimaces. A common sign to look out for is a sudden drop in oxygen saturation too. In the final stages of the swallow, in the esophageal stage, people might feel pain when swallowing. They might get a sensation of food sticking in their chest. A little later on, perhaps undigested food gets regurgitated, or people might experience heartburn or an acid taste. To finish with, I'm going to highlight some more general signs that might indicate someone might be struggling with dysphagia. People may show less interest in their food and drink in general and take smaller amounts than usual as a result. Perhaps people might change what or how they are drinking. They might adapt their diet and opt for foods that are softer and easier to chew. There might be unexplained weight loss and dehydration as less food and drink is consumed. Some of this food and liquid might get aspirated into the lungs, which leads to recurrent chest infections. So these are some of the more common signs and symptoms of dysphagia, but as above, this list is by no means exhaustive. So that's an overview of what dysphagia is, where the word comes from, the difference between oropharyngeal and oesophageal dysphagia, what causes it, and what the signs and symptoms can look like. If you found this video useful, make sure you like it and subscribe to the channel. If you want to find out more about how dysphagia is assessed or managed, then watch some of the other videos on the channel. Otherwise, thanks for watching and take care.